This is Megaphone from Medvale Media. I'm Dave Self. This is where we hand the megaphone to healthcare leaders to share their thoughts, their perspectives, and the occasional rant about this increasingly crazy and interesting world of healthcare. It is a true privilege today to welcome longtime Medvale resident Jesse Arnoldson, founder of Value Care Group. Jesse, welcome to Megaphone.
Thank you for having me. Excited to be here.
Yeah, it's taken a while. I'm glad we finally got everything to sync up. So, Jesse, why don't
Yeah.
you kick us off with your journey from your roots to Idaho State University, go Bengals, and to where you are today?
Yeah. Yeah. I love my roots. I am an Idaho boy through and through. I grew up over in eastern Idaho near Blackfoot, in a little tiny town called Springfield, population about 56-ish. Um, and I I grew up there, and the whole time growing up wanted to leave Idaho, wanted to get out, go do something different. Um, Spent some time in the Caribbean, spent some time up in Alaska, trying not to grow up, trying not to be too mature or any of that. Um, I ended up meeting a girl while I was up cutting fish in Ketchikan, and she was from Idaho, going to Idaho State University, and ended up bringing me back. Yeah, we
Wait a
speaking
minute.
of
You had to go,
trying not,
you had to go to
yeah,
Ketchikan, Alaska to meet someone
yeah.
from Idaho.
Yes, right,
Oh
right.
man.
And she brought me right back. I started a job as a bank teller. I started going to Idaho State University, and I got married all in the same week of coming back. And and just been going ever since. And so while I attended ISU, like you said, go Bengals. It's an incredible school. Um, just a great group of professors and students, and just so many amazing programs in and out of the classroom. And so I benefited greatly from my experience at Idaho State. Um, Part of that was actually a a an internship where Idaho State paid me, not a ton, but a little bit. They paid my wages and let me go out and do projects and work for other companies. And one of those projects was for a company called MedMan, or medical management. For those that don't know, that was our Medville founders, Jim Trounson, his first company that he started back in 1977. And I got to meet Jim and do some project work for him, and I loved what he was doing. It was a little bit scary, and he was very open about his small business and just everything that he had been through over the decades. And um, I don't think at the time I realized that every business has though that that it's messy. Business is messy, especially healthcare business. And I was a little scared of jumping on. But about 10 years ago, Jim found me lurking around the Idaho Hospital Association conference in Sun Valley as a student, and put his arm around me and walked me away from all the hospital CEOs, and was just like, Jesse, I don't know what the hell you're doing, but you're going to come and work for MedMan. Where this is what you're going to do. And so, that tactic worked. I ended up coming to MedMan, coming over to Boise, and I spent 10 years with that company. 3 of them with Jim at the helm, and then about 7 of them as one of the partners that bought the company from MedMan, from Jim, and then ran it. At the end of 2024, I kind of found myself at a turning point where um, I needed to make some kind of harder decisions on whether to keep going or to try and go out and do something else. And I was listening to your show where you were interviewing Jeremy from Mississippi, and he made a comment of, there are times where you either need to lead, follow, or get out of the way. and I couldn't be the kind of follower that my other partners needed me to be. And so it was time to get out of the way and let them do it. So I ended up leaving, and um, which was one of the hardest decisions I've ever made. MedMan was part of my DNA. It was really my identity for a long time, and I still love that company and the people in it. But it was a very opportune time to break out on my own, to kind of force me to leave the nest and try something different. And that's where Value Care Group comes into play. Where I was able to come out, you kind of do what you know. So Value Care Group is a management company, and but instead of focusing on the operations and the management of a medical practice like MedMan did, this is where we focus on the startup and the ongoing management of what's called a clinically integrated network. And so Value Care Group helps small primary care offices, whether in private practice, in small rural hospitals, or in FQHCs, come together, maintain their independence, but find a way um, to build some critical mass with one another and use that as leverage to go out to payers and start doing contracting, mostly in the value based space.
Right.
Today, I think MGMA reported that 20% of total medical revenue for family practice comes from value-based reimbursement. The sorts of agreements that we set up for shared savings, bonuses for meeting quality metrics, um, bonuses for meeting certain coding standards, and most of the groups that I know that run around and that I run around in their circles are not big enough to go out and develop those sorts of arrangements themselves. A
Sure.
two
Well, just
doctor office,
just
yeah,
the practices, the practice of being in that game alone can be an expensive proposition if you're a small
right,
practice.
absolutely. You imagine being a two doc shop in Wendell, Idaho, and you go to a Blue Cross of Idaho and say, "Hey, I want to have a value based agreement. I hear that that's where most of my reimbursement is shifting to, or 20, at least 20% of it. What can I do?" And Blue Cross will say, "You've got 40 people in that pool of lives. We're not going to do anything with you. We just can't. We can't contract at that level." But if that office and an office from First and an office from Standpoint and another one from Twin Falls all come together, they start to build a real thing, a number of lives, a critical mass. And we use that to go after those dollars that are just unattainable to an office like that on their own. Um, but the idea is not just to be a contracting body. We want to be a performance one. We want to help them actually succeed, to compete with the big boys in the market, and do just as well, if not better, at improving the health of their patients, at lowering the cost of care, at just disrupting the healthcare system as a whole. So that's what we're up to.
Well, let's stick on this for just a moment and
Yeah.
tell us what inspired you to dive into value-based care, number one.
Mhm.
Yes, it's an emerging area or fully emerged, I guess, now and growing in most parts of the United States. But why value-based care? Why not hit the easy button and do something with fee for service?
Right.
And I focus on smaller independent healthcare practices. It's a lot more work. I mean, the work for a small practice is pretty much the same work for a much larger entity, correct?
Yes, very much so. Um, I think you nailed it that this is an emerged market. We've been going at this for what, 15 or 20 years of preventative care and breaking the cost curve, and what used to be MIPS, and then before that was PQRS, and all these different programs that have come and gone. And what I see is failed. Our healthcare is more expensive than ever. Our per capita primary care provider population in Idaho is as low as it comes. It's harder and harder to stay in
We're
private
last in the
practice.
nation.
Yeah,
Yeah,
yeah, we
we're
are.
bottom of the barrel.
So, and yet I don't see things changing in a meaningful way to change the trajectory of those things. Um, and so at a certain point you kind of sit there and you're like, well, I don't see the other people who I would expect to be doing this doing it, or I don't see the people that are, the smarter people or more equipped, better funded, better experienced people doing it as much. Like there really are those kinds of people, but not in mass, not to the point where this thing is changing in any significant way. And not only that, but my 10 years in practice management, it was mostly with the independent. It was my friends that started 2 doctor pediatric practice in Meridian. It's my friends that have a 20 plus year family practice in Sandpoint who are under the constant threat of not being in business anymore, you know? And I think that at some point, this promise of value-based care has got to actually come through. And I don't think it's going to be the next federal MIPS program, MIPS-like program that's going to do that. I think it's going to come from those more at the grassroots level believing that they can make the change and forcing it to happen. And, why do it on the smaller guy scale? Because there just isn't anybody there doing this work with the people that, you get to know them, you get to see these practices, you see the kind of care they deliver, that is probably the highest level, low cost care provided in anywhere in the healthcare sector. And yet they continue to be kind of kicked in the teeth, whether it's funding or regulation or competition with the bigger groups, and so I have a real soft spot in my heart, not just for primary care, not just for Idaho providers, but for those smaller ones. And I think that we can do the most good there.
Let's pull apart value-based care or value care for just a
Yeah.
minute, if it's okay. You're right. We've been
Please.
on this journey for a long time, really longer than 20 years. I mean, you can trace this all the way back to the HMO days of the 90s. You can fast forward
Yes.
Hillary Care, and then it became point of service plans because we failed at the HMOs. And largely, there are some
Yeah.
exceptions, obviously. Kaiser is an example of where a
Mhm.
closed panel can work. But as you fast forward, then point of service kind of went, kind of died out a
Mhm.
little bit. We didn't hear anything for a few years, and then suddenly it was all about population health and the triple aim
Yes.
and now the quadruple aim, and we just keep rebranding this, but we haven't really moved the needle on something that you touched on. So I'd love to hear your thoughts around this. How do we take success in value-based care and actually decrease the total cost of care to the people that need it, the consumer, the
Yeah.
member, the patient? How do we translate success and value to lower out-of-pocket either premium or benefits?
It's interesting. I think of 2 big programs that out of all of them, the ones you just listed plus the 30 more that we didn't, I can only think of really 2 big programs that drove a meaningful decrease in the cost of care. One is the medical home model, and that's where we transform primary care offices from that of like almost like an urgent care with banker hours to a true medical home that ties a patient to the PCP, where there's a relationship that goes beyond the office visit, where they are managing chronic conditions, where they are the very first thought and phone call for anything that's gone wrong, where they are truly pushing wellness and at the same time able to track that wellness baseline to know when something's gone wrong, right? So this medical home model, And I'm not necessarily promoting like a full extent to the patient-centered medical home standard that NCQA, the PCMH certification that NCQA does. I think that that's a great program that comes with a lot of administrative burden, and that can be tough. But
Yes, it
but this
does.
the idea of expanded hours, beyond just Monday through Friday, 8 to 5. Um, Being able to communicate with your provider outside of that in different ways, whether it's um, answering service after hours or communicating to the portal or whatever it may be, being able to have access to records, uh, and having your PCP communicating with the rest of the ecosystem and getting your patient data out there. Um, all of these things play into uh, patients avoiding the emergency room, patients being diagnosed properly and timely. Um, I think that oh, and I'm sorry. I was thinking about a different story, but I'll kind of rewind a little bit. But being able to get diagnosed properly and timely um, has played a huge role in diminishing the more exasperated care costs that we see quite often. So the medical home model is the first thing. The second thing is more of this, and it's sort of related. You could probably tie the two together, but this chronic care management it's continuing to evolve. We're seeing it play into more of this APCM model, advanced primary care management. But studies have shown that patients under the chronic care management we were able to reduce the total cost of care for those patients by about 20 to 30%. The same goes for the medical home model, where we're reducing emergency room utilization by about 25%. That is where we're able to get the best bang for our buck. Yes, we can go out after that and try a few different things with specialists. There's a lot of room in pharmacy and PBMs, but being able to provide a much more comprehensive, high touch medical home closest to the patient as possible, that's where I think that we're going to see value-based care actually have an impact on that cost trend.
You make a compelling case. Here's where the cognitive dissonance sets in for me.
Yeah,
Everything you said can be achieved. How do we get more of the value to fall to the people receiving care? Because in
yeah,
between, in most every case, and self-pay is a very small percentage of the population. People who pay the bill themselves, they
mhm,
don't have insurance, they have the means enough maybe to go without. But the folks that do rely on commercial insurance, on Medicare, on Medicaid, where there's any place that there's any out of pocket, a copayment, and a
yeah.
deductible, um, and a premium, how do we translate what you talked about through that without cooperation from the payer ecosystem?
Right. Oh, so there's two parts to that, right? And I'll share my own personal story. Um, my I had my middle kid. He was probably about 5 years old at the time. He was a little bit sick. He had woken up and thrown up in his bed. Um, and we were able to get him out and get him into a bath. We didn't realize he was running a fever. Once in the bath in that hot water, it triggered a seizure, um,
Oh my.
uh, uh, a febrile seizure. And we had the ambulance there. We had my pediatrician on the phone. This is Sunday at 7 p. Or no, it was Sunday. It was after hours. It was probably about 10:30 p.m. And while I had my pediatrician's cell phone number, I did go through the proper phone number because I didn't want to take advantage of that. But I ended up back to him anyways right away. He was the physician in their office on call. He was able to talk us through what was going on, able to FaceTime with us, able to communicate with the EMTs, and able to comfort us at the time that it wasn't something that Christian needed to go to the emergency room. We avoided an ER visit, which for us would have been probably traumatizing and scary and exhausting. Would have been the same, if not multiplied, for our son Christian. We have an HSA plan through the state marketplace, commercial plan, with about a $16,000 deductible, family deductible. That saved us from probably having to take on the full brunt of that ER visit.
Right.
Um, our pediatrician checked in on us the next day, and then 3 days later, and the care coordinator checked in, continuously after that, to the point where it kind of fell off because everything had been taken care of. Our avoidance of the ER and the emotional trauma that would have caused, our comfort in knowing that our son was okay, beyond just us hoping and guessing and praying that we weren't just being cheap and not going to the ER, right? And the fact that we weren't having to spend all of that was provided because of medical home concepts and a fantastic pediatrician, um, in a small independent setting. Had we not had that sort of setup, if we couldn't contact our physician outside of regular hours, if we couldn't have that kind of relationship with our doc, if we hadn't been encouraged to be getting our well child checks and having that established baseline with that office, um, that wouldn't have happened. We would have been at the ER for sure and having to experience all of that. Now, how does that get done without the payer's help? It doesn't, unless it's basically off of the charity of these pediatricians and family practice docs. And I know that we don't like to lose a lot of tears for physicians and their compensation, but pediatricians and family practice are at the bottom of the compensation totem pole for all
Yes.
physicians. And when you're in a small business running it as a pediatrician, you know, that compensation varies wildly. And a lot of times that kind of care is charity work. Currently in the state of Idaho, for the last, 10 years, that model has been supported by the Medicaid program. Department of Health and Welfare had a medical home model that financially incentivized offices to move in that direction, even to the point of becoming PCMH certified. We just legislated that away. There was a whole lot of stuff that was designed in our last session, and a lot of things went away. A lot of bathwater. The medical home was the baby that went out the window with that bathwater, and we're at a point right now where nothing financially um, supports those programs, and it requires our legislators to take another look and be serious about it. But it also requires the other commercial payers in the state to get into it. And I'm not bashing them, not cutting them, but they've all benefited from the same programs
Right.
that Medicaid paid for. Blue Cross of Idaho, Regents Blue Shield, United Healthcare patients all at midnight as well, not just Medicaid patients. And those programs are there because of that. So I think it's time for us in Idaho to come together and support what has been probably one of the very few value-based programs at large that has been truly successful.
Is there a piece of the typical value based care model that you think is suboptimal? Is there something that, you know, Jesse
Yeah.
Arnoldson is the monarch of the moment? You've got some magic in your hands. You're going to make a change. What would that change be?
Right now, I don't know that the shared savings model is absolutely dead in my eyes, but it is broken.
Well, so, but before
Uh,
we go on, why don't you
yeah,
define shared savings for people maybe outside
right,
Medvale that aren't familiar with what
right.
that is, please?
So let's say a payer, ABC insurance company, and XYZ family practice come together. And XYZ family practice has about 500 uh, of their patients that use ABC insurance company.
Okay.
And they say, hey, we want to lower the cost of care. Um, why don't we set a budget with a target? And if those patients, if XYZ family medicine can help lower the cost of care to where we beat that trend, that target, and as a budget, we do better, then some of that money can go back to the family practice clinic in the form of shared savings. Some of that will go back to lowering the cost of premiums. If it's a for-profit company, then if ABC Insurance Company is for profit, then they get some of it. Um, that's the model, which is simple enough. There's a
Sure.
budget. We think it's going to cost $1 million. We come in at 800,000. Family practice, XYZ family practice gets 100,000, and the remainder goes back to lowering the cost of premiums going forward. It
Got it.
is. I like the model. I truly do. What I think is broken is that for the last several years, let's say 4 years, our trends and targets have not been set well. And I think before that, there was just a whole lot of money. Like things were going well on the insurance side, and people probably just accidentally did well in those shared savings programs. Now that money is tight, targets and trends are high, utilization is higher than it's ever been. None of us are meeting those goals, those targets. And so we continue to chase the the rabbit on this. We keep trying our very best to do these things. We shift our referral patterns. We we hire a lot of staff to keep people from going to expensive places of care. That same staff works really hard on getting them in for annual wellness visits. We move the needle on all these different things, and yet these programs aren't paying out. And we just saw the Medicare Advantage plans get posted for 2026, plans and
Right.
pricing. Anywhere that we were doing well, all of a sudden, nobody wants to touch Medicare Advantage right now. So they all have jacked up their prices. They've left counties. They've left the market altogether. They've cut benefits, and so I think that for me is probably the hardest part. If you're sitting as a family practice doc, the the goal line has moved 20 different times. You're not even sure where it's at anymore. And for me, part of my responsibility is to find that goal line, find that window of opportunity, and make sure that we are at the table and that we're performing so that we get it. It's just that it we're not quite sure that we're there yet. This is what we're pumping towards. This is what we have to succeed at.
So give me a 60-second sales pitch. You walk into Dr. Dave's office and you're talking to me and my clinic manager, and Value Care Group is there to pitch themselves. What's the 60 or 120-second pitch to tell
Yeah,
everyone viewing and listening what it is you do?
yeah. For the individual office, it is typically that you have something pretty dang incredible going on inside of your office. Something that at your size is not appreciated as it should be. And you have neighbors down the road that feel the exact same way, and you're not alone on it. And not only are you not appreciated, but we continue to just be steamrolled through every legislative session, through every back office meeting they have at whatever insurance company. Um, and at best, we keep being tag-alongs to whatever our local health system is doing. And I'm not anti-health system. I'm very pro health system. But what I've noticed is that the little guy, we have a lot of us. There are a lot of little guys in Idaho. There are a lot of really amazing rural private practice, small hospital providers out there that together we have critical mass and we have voice. I think that it is all in all of our best interest that we start to align with each other. Not that we're going to eliminate our relationship with the big hospital in our locale. We have to have a
Sure.
relationship with them. But when it comes to value-based contracting, payer contracting, um, and perhaps other innovative ideas that are coming down the pike, I think that we're better aligned as the David, David and Goliath story, the Davids of primary care, than we are with anybody else. And if we can do this, if we can come together, then we can get the best of both worlds. We can maintain our independence, our autonomy, while at the same time enjoying the benefit and the leverage that comes from a bigger size. And so that's where I'm coming from is, can we bring these groups together? Value Care Group is behind the scenes. We want these providers to help to come together and create their own network. We call it a clinically integrated network. That's just the legal term for the umbrella that this can all fit
Right.
under. This isn't something that's owned by Value Care Group. The payers don't own it. The hospitals don't own it. Department of Health and Welfare doesn't own it. They own it. It's theirs. Value Care Group just wants to be a part in making sure that it runs successfully and that it can get done and perform well. So that's my message, is to keep moving forward with pride in your independence, in your small business form, in your rural setting, but do it with your fellow providers in the same situation.
So let me feed that back to you and make sure that it's clear, at least in my
Yeah.
mind. You're more than a matchmaker. I mean, you're more than just bringing together these disparate practices, saying, "Hey, together
Mhm.
you're stronger." You're actually providing a service behind that to facilitate the
Yeah.
model. Is that
Right.
correct?
That's right. I hadn't thought about it as a matchmaker, but I think the first step is that it's matchmaking. It's bringing home, yes, they're the private practices, but on the other side, we've created a network for all the small non-system based hospitals in the state. So it's bringing together Valor from Emmett and Madison from Rexburg and Boundary from clear up north. That we play that matchmaker role, but then we provide the the experience and the knowledge to help them actually perform well. So we bring them all together. We go to the payer and say, "Hey, we need a contract." We negotiate that, and now we're going to perform the heck out of that contract to get these primary care clinics funded. That's it.
Well,
Yeah,
that's not much. Good grief.
not much.
And you're welcome to include the idea of matchmaker in your next pitch. Go ahead. Knock yourself
Heck
out.
yes. Heck yes. I'm sure there's a whole song we could create about it too.
So how long have you been taking Value Care Group to market?
Right. We started our very first clinically integrated network about 5 years ago, but that was when I was at MedMan. And so we've been running off of this single network, trying to get the recipe right.
Okay.
Value Care Group has been running since February 1. And Community Care of Idaho, the small private practice network that we started several years ago, came with. The Hospital Network of Idaho is what we're in the middle of creating. We've incorporated. We're setting up our nonprofit. We've got our board of directors finally voted in as of a couple of weeks ago. And we'll be roaring to go by January 1, 2026. And then it's going to be, I think that these two networks will be the vehicles through which we approach a lot of the new programs coming out. Medicaid managed care is coming down the pipe, and we have about 3 years to prepare for it. We'll use these networks to uh, engage with the NCO hopefuls, identify who we want, lobby for them, lobby against the ones that aren't going to be pro primary care in our state, and then help them perform. As Medicare Advantage maybe evolves and hopefully improves, we're going to be there for that. As we have opportunities to do anything else, that's what I think that these collaborative relationships are going to provide.
Well, Jesse, Maria, the producer, director, and all-around technician for this broadcast, and I have been building out our own travel log of great places to eat and things to do. So
Uh,
every guest gets a chance to share with us some insider guidance. what is the must-do activity folks should know about that you like to do? Sounds like you've got a family, so maybe it's what's a great
Yeah.
family thing to do, and a couple of great local taste treats to check out too.
Local things to do. I'm going to give a couple. I'll give a speed run because I am fortunate. I get to go around the state quite a bit. So I get to go from everywhere from Boundary County at the very peak on the Canadian border over to southeastern Idaho by West Yellowstone. Um, to do, I would snowboard Schweitzer in Sandpoint. I would dirt bike in Weiser over in western Idaho. I would spend every waking moment I could in the summer in the Sawtooth, backpacking and hiking around there. And and what would I do in eastern Idaho? I would spend a lot of time in Lava Hot Springs, soaking it
I
up.
was waiting
Yeah,
for you to get to Lava Hot Springs. So yeah.
yeah, yeah. I'd go there in the winter and sit in the natural hot pools and let my hair freeze while I soaked there. And then to eat, uh, if you haven't had it, Tangos in Meridian is Argentinian slash Mexican husband and wife. I think the husband's from Mexico City and the wife's from Argentina, and they have an empanada restaurant both in Boise and Meridian, and it is one of my favorite, hidden secrets in Idaho. Yeah,
Well,
empanadas are so good.
you just made a friend with Maria. She is native
Yes.
Argentinian, so she's all about the empanada.
When Maria comes up, I will make sure we don't miss that.
Excellent. Well, Jesse, you get the last word. What message would you like to leave us with today?
Yeah, I think that um, life is way too short to not be fully involved in something that you're passionate about and that is making the world a better place. And I am just super grateful that what I do fills that bucket for me. And I think that, I've had a number of conversations the last few weeks with friends that are unfortunately not in the same position, and they are working their tails off for something that's not going to love them back and that's not going to create anything better in our world. And I wish I could say that I fully chose this path all on my own, autonomously from anybody else. I was kind of forced, the world just happens, and sometimes you go where the world's taking you. But I am very fortunate to be living in that, and that has made me a better human all around, a more present father, a more loving husband, and just way more engaged in the work that I'm doing. Not working any less, not working any easier, but just enjoying what comes from it, and challenges become a very different thing when it's presented in that light rather than in the world is falling apart and I have nothing left to give it because my tank's empty. So finding your purpose and finding your mission, something that is that gratifying, can just make a world of difference in how you're living your life. So yeah, I'll leave it at that.
Jesse, thank you very much. We've been talking today with Jesse Arnoldson, founder of Value Care Group. Jesse, it's been a privilege. Thank you for making time. We're fortunate to have you in Medvale. And that's it for this edition. But join us next time for Megaphone. From Medvale Media, I'm Dave Self. Be well.